Calcium channel blockers, mechanisms and clinical use. Dr. Rasha Abdelkarim, Pharma Basics for educational use only. Hey everyone, welcome. I'm Dr. Rasha, specialty pharmacist, and this is RxRasha Pharma Basics. Today we're starting a two-part series on calcium channel blockers, CCBs. In this first video, we cover how they work, the two subclasses you must know, and when a clinician chooses a CCB over a beta blocker. Part 2 will go deeper into safety, contraindications, and patient counseling. Let's go! How CCBs work. Calcium is not just a bone mineral. Inside muscle cells, heart muscle, and the smooth muscle lining, blood vessel walls, calcium is the trigger for contraction. It flows in through voltage-gated L-type channels, activates the contractile machinery, and the muscle squeezes. The heart pumps harder, vessels constrict, blood pressure rises. Calcium channel blockers physically block these L-type channels. Less calcium in, less contraction. That single mechanism explains every therapeutic effect CCBs produce. CCBs block L-type voltage-gated calcium channels, leads to less calcium entry, leads to reduced contraction of heart and/or blood vessels. The two subclasses, DHP versus non-DHP. Here is the concept that separates confident clinicians from confused ones. There are two completely different CCB subclasses acting on different tissues. Getting this wrong in clinical practice can be dangerous. Dihydropyridines, DHPs, the vessel drugs. Amlodipine, nifedipine, felodipine. DHPs are highly selective for smooth muscle in blood vessel walls. They cause powerful vasodilation, dropping blood pressure. Minimal direct cardiac effect. The one cardiac consequence you will see, reflex tachycardia. When blood pressure drops suddenly, the sympathetic system compensates by speeding up the heart. Amlodipine is the gold standard. Long half-life, once daily, excellent tolerability, and fully safe in asthma and COPD. Non-dihydropyridines, non-DHPs, the heart drugs. Diltiazem and verapamil. These act on both heart and vessels, but the dominant effect is on the SA node and AV node. They slow heart rate, slow AV conduction, and reduce contractility. That makes them antiarrhythmics, especially for rate control in atrial fibrillation and SVT. Never combine a non-DHP CCB with a beta blocker without close monitoring. Both slow the AV node. Together, they risk severe bradycardia, AV block, or cardiac arrest. Key drugs at a glance. Amlodipine, DHP, once daily, half-life 30 to 50 hours. Indications: hypertension, chronic stable angina, vasospastic angina. Side effects: peripheral edema, flushing, reflex tachycardia. Safe in asthma, COPD, and most patients with reduced ejection fraction. Nifedipine, DHP. Extended release only for hypertension. The immediate release form causes rapid BP drops and is linked to increased MI risk. Indications: hypertension, angina, Raynaud's phenomenon. More reflex tachycardia than amlodipine. Diltiazem, non-DHP. Indications: angina, hypertension, AF, and SVT rate control. Monitor heart rate and PR interval. Preferred non-DHP for patients with angina and hypertension who cannot tolerate beta blockers. Verapamil, non-DHP, most cardioselective CCB. Indications: SVT, AF rate control, hypertension, hypertrophic cardiomyopathy. strong negative chronotropic and inotropic effects. Also inhibits CYP3A4. Watch for drug interactions. CBS versus beta blockers. Choose a beta blocker when post-MI. Mortality benefit is guideline mandated. Heart failure with reduced EF. Bisoprolol and carvedilol are first line. Angina with tachycardia. Unique indications: migraine prophylaxis, essential tremor, performance anxiety. No CCB covers these. Choose a CCB when asthma or COPD. DHPS are safe, beta blockers risk bronchoconstriction. Vasospastic angina. DHPS are first line. Beta blockers can worsen vasospasm. Peripheral artery disease or Raynaud's. DHPS are better tolerated. Elderly with isolated systolic hypertension. Amlodipine is excellent. Combination therapy. Beta blocker plus DHP. Safe, common, complementary. Metoprolol plus amlodipine have additive BP lowering, and the beta blocker counters reflex tachycardia. Beta blocker plus non-DHP dangerous. Combination as both slow the AV node. Avoid unless under close specialist supervision. Quick recap. DHPS dilate vessels, so blood pressure is their target. Non-DHPS slow the heart, so arrhythmias are their territory. And combining a beta blocker with a non-DHP is one of the most important drug interaction warnings in cardiovascular pharmacology. Part 2 covers precautions, contraindications, and patient counseling. Subscribe so you don't miss it. I'm Dr. Rasha. Thank you for being here. See you in Part 2. RxRasha, Pharma Basics, Dr. Rasha Abdelkarim, Specialty Pharmacist. For educational use only.